Welcome to the deep dive. Today we're really digging into a major study about a peripheral artery disease PAD and, well, it's pretty serious complications.
That's right. We're focusing on the COMPASS trial, specifically looking at what it tells us about major adverse limb events and mortality in patients with peripheral artery disease.
And you're going to hear some, frankly, eye-opening numbers, like just how much the risk of needing another amputation jumps after someone has one of these severe limb events. Okay, let's get into it.
Yeah, our goal here is pretty clear. We want to understand the risks for people with PAID who have these major adverse limb events. We call them MAIL for short.
Bailey, got it.
And also look at a potential treatment from the COMPASS trial that might help lower these risks. So if you want a solid grasp of key developments here, you're definitely in the right place.
Absolutely. So let's start with the basic problem. We already know that patients with PAID, especially in their legs, have a higher risk of, well, both major heart problems, MAIL-E, like heart attack, stroke, and these limb events, MAIL-E.
Right. But what this specific analysis really highlighted was this gap in understanding. We knew PAD-E was serious, but what actually happens to patients after they have a MAIL, that wasn't nearly as clear.
And that's where COMPASS comes in. This analysis of the PAD-E patients in that trial gives us some really valuable clues. The main trial itself was pretty large scale, wasn't it?
Oh, yeah. It was a big one. Randomized, double-blind, placebo-controlled, the gold standard for clinical trials.
Meaning it's designed to be really rigorous, reducing bias. Patients randomly get the treatment or a dummy pill, and nobody knows who's got what until the end.
Exactly. And within that big trial, for the PAD group specifically, they wanted to answer two main things.
Okay, what was the first one?
First, they wanted to see if things like hospital stays, so a heart attack, stroke, cardiovascular death, amputations, and just overall death happen more often in PAD patients after they'd had a MAIL compared to PAD patients who hadn't.
Makes sense, comparing those two groups.
Yeah.
And the second objective?
The second was all about treatment. They tested whether giving low-dose Rivaroxaban, that's a blood thinner, along with aspirin, worked better than just aspirin alone.
Better at preventing what, specifically?
At preventing MAIL-E itself, peripheral vascular interventions, things like angioplasty, stents, bypass surgery in the legs, and just generally other bad vascular outcomes.
Okay, good. So before we jump to the findings, let's just be super clear. What exactly is a MAIL-E in this study?
Right. So MAIL major adverse limb event, it means the limb is suffering from severe ischemia, basically not getting enough blood flow, which is dangerous, causes pain, puts the limb at risk.
Okay.
And that situation then leads to either needing an urgent intervention like surgery or a procedure to restore blood flow, or unfortunately it results in a major vascular amputation.
Got it. So really serious limb-threatening stuff. Now, the findings, what did the study actually show happens after someone has a MAIL? This is where it gets, well, pretty stark.
It really does. The numbers are quite concerning. They found that within 1 year after having a MAIL, patients had a 61.5% cumulative risk of being hospitalized again.
Wow, over 60%, that's a lot. And it gets worse from there, right?
Yeah, tragically. The risk of needing a vascular amputation within that same year was a staggering 20.5%.
20%. So 1 in 5 people needed an amputation within a year of that first major event.
That's what the data showed. And the risk of death wasn't insignificant, either 8.3% within that year. And finally, the risk of having another MACE, another major cardiovascular event, was 3.7%.
So it really drives home that a MAIL isn't just a one-off bad event. It signals a much higher risk for more problems down the road. Did they quantify how much higher the risk was, like with hazard ratios?
They did, yeah. And those numbers really underscore the point. After a MAIL, the risk of ending up back in the hospital increased by a factor of 7.21.
7 times higher.
Okay.
And the amputation risk. That one really stood out to me.
Yeah, that one is, well, it's almost hard to believe. The hazard ratio for a subsequent amputation was 197.5.
Whoa. 197, nearly 200 times the risk.
Exactly. It just shows how incredibly vulnerable patients are after that initial MAIL event triggers this cascade.
That's just, yeah. What about the risk of death?
Also significantly higher, the hazard ratio was 3.23, so over 3 times the risk of death after a MAIL. It paints a pretty grim picture, unfortunately.
Okay, definitely establishes the severity. So now let's turn to the potential positive side, the treatment they tested. This combination of low-dose Rivaroxaban plus aspirin. How did that compare to just aspirin?
Well, here the news was much better. The combination therapy showed some real benefits. Specifically, they found a 43% reduction in the risk of having a MAIL compared to the aspirin-only group.
43% lower risk of those severe limb events. That's really significant.
It is. And it wasn't just Maley. They also saw a 58% reduction in total vascular amputations.
58%. Almost cutting the amputation rate by more than half. That can make a massive difference for patients.
Absolutely. And there was also a 24% reduction in the need for other peripheral vascular interventions, like needing a stent or bypass.
Okay.
And overall, a 24% reduction in sort of all peripheral vascular outcomes combined.
So pretty consistent benefit across different types of limb events. I think the study mentioned people on aspirin alone were basically twice as likely to have a male or an amputation.
That's right, roughly double the risk compared to the combination group. But we absolutely have to talk about the other side of the coin with these kinds of drugs.
Which is bleeding risk.
Okay.
Always the trade-off, right?
Exactly. You're thinning the blood more, so there's a higher chance of bleeding. The study did find that.
Yeah.
Major bleeding happened in 3.2% of patients on the combination therapy,
Okay.
compared to 2.0% in those just taking aspirin.
So an increase, yes.
Right.
About 1.2 percentage points higher, something that definitely needs to be weighed against those big reductions in limb events and amputation.
Precisely. It's always a risk-benefit calculation.
Now, one really interesting part was looking at outcomes after someone had already had a male. How did the treatment they were on influence what happened next? That seems super relevant.
Yeah, this was maybe one of the most striking findings. For patients who had already experienced that initial male, if they were only on aspirin, well, their outcomes were much worse.
How much worse?
They had a 6-fold higher risk of death, and get this, a 10-fold higher risk of having either another MACE event or another amputation compared to those who were on the combination therapy.
10 times higher risk of death, MACE, S, or amputation, if you were just on aspirin after that first male.
Compared to being on the combination, yes, 10 times.
Wow. That's a huge difference. It really suggests this combo might be particularly protective for those very high-risk patients who've already gone through a male.
It certainly points in that direction quite strongly.
Okay, let's pull back a bit and look at what experts made of all this. What was the general commentary?
Well, experts really highlighted that this study gives us much-needed, updated info on what happens to patients after a male, and it provides strong evidence for this specific drug regimen, the Rivaroxaban plus aspirin, as something that could really reduce complications for payday patients.
And they also pointed out the study context, right? That this was a specific look at the payday patients within the bigger COMPASS trial.
Exactly. The whole trial compared aspirin alone, Rivaroxaban alone, and the combo therapy in patients with stable coronary artery disease or PAY-PAY. This analysis zoomed in on the roughly 6,400 participants who had PAYD in their lower limbs.
And who were these payday patients exactly? It wasn't just anyone with mild symptoms, was it?
No, they had fairly significant disease. To get into this subgroup, you needed a history of things like bypass surgery or angioplasty in your leg arteries, or even a prior amputation because of arterial disease.
Okay.
Or you had confirmed claudication, that pain when walking, or you had known coronary artery disease plus a low ankle brachial index, which is a test confirming PAD.
So a population with established significant PAD. And just as important, who was excluded. That helps define who these results apply to.
Right. Safety and study integrity meant excluding certain people. Those with a high bleeding risk, obviously. Also, recent stroke, severe heart failure, bad kidney disease.
Okay.
People who already needed other strong blood thinners or dual antiplatelet therapy, or had liver problems affecting clotting. So, it wasn't tested in those specific groups.
That's really important context for thinking about applying these findings in the real world. Now, like any study, this one had limitations. What did people point out?
Yeah, transparency is key. A main one is that it was a subgroup analysis. While there were lots of PAD patients overall, the actual number of male events wasn't huge.
Meaning the study wasn't primarily designed just to look at post-male outcomes.
Exactly. It's more of an observation from the data collected for the main trial questions. And that smaller number of male events might be why some known risk factors, like smoking or diabetes, didn't pop up as statistically significant predictors in this specific analysis.
Right. Sometimes you need more events, more data points, to reliably detect those kinds of links.
Precisely. Another limitation related to the sample size was that it made it hard to slice the data even finer, like breaking it down by age groups to see if, say, younger patients got more benefit with less bleeding risk compared to older patients.
That kind of subgroup analysis is often tricky with smaller numbers.
Yeah, there's a hint younger patients might do better, but this study couldn't definitively show that.
And there was also the standard disclaimer about funding, right?
Yes, it's important to note the study was sponsored by the companies that make the drugs involved, and some researchers had financial ties. It doesn't invalidate the findings, but it's something listeners should be aware of, potential for bias.
Standard practice to disclose that. Okay, so limitations acknowledged. How has this study actually impacted things? Is it seen as practice changing?
Oh, definitely. Compass is widely considered a landmark trial for PAD. Why? Because it was really the first big trial to show such a clear net benefit, meaning the benefits clearly outweighed the risks for preventing male heart events and death with this kind of combination therapy.
Before this, what was the standard approach?
Typically, just a single antiplatelet agent, usually aspirin or clopidogrel. Previous attempts to use dual antiplatelets or other anticoagulant combos in PADI hadn't really shown this level of clear overall benefit.
So this was a breakthrough. But are there still debates about applying it?
Absolutely. The bleeding risk is always a major concern, especially when thinking about using it broadly. Should it be used in all PAD patients, even those without symptoms, or mainly in those with symptoms or those who've had procedures? The trial data makes detailed stratification difficult, as we mentioned.
And the exclusion criteria we talked about, like excluding people with atrial fibrillation who need anticoagulation anyway, means the trial results don't directly apply to every single PA patient you might see.
Exactly. And there was an interesting recent analysis looking at number needed to treat, how many people you need to treat to see one benefit versus one harm. It suggested younger patients might indeed have a better benefit to harm ratio, but again, we need more age-specific data.
And you mentioned another trial earlier, Voyager Pad. That seems relevant here too.
Yes, Voyager Pad is looking specifically at using this Rivaroxaban aspirin combo right after patients have had a revascularization procedure for PAD, like getting a stent or bypass. That's a super high-risk period, and Compass didn't focus specifically on those patients right after their procedure, so Voyager will add another important piece to the puzzle.
Okay, we've covered a huge amount of ground. Let's try to boil it down. What are the absolute key takeaways from this deep dive into Compass and male?
I'd say two main things. First, experiencing a male is incredibly serious for PAD patients. It dramatically increases their risk for more hospitalizations, more amputations, and even death. We have clearer numbers on that now.
Right, the prognosis after male is poor.
And second, the combination of low-dose Rivaroxaban plus aspirin looks very promising. It showed a significant ability to reduce the risk of male amputations and other vascular problems compared to aspirin alone.
And it's a crucial, we always have to remember that increased bleeding risk that comes with it.
Absolutely, it's not a free lunch. That bleeding risk needs careful consideration for every single patient, weighing their individual risk factors for both clots and bleeds.
And clearly the story isn't over. Compass was huge. But research like Voyager Pad and further analyses are still needed to figure out exactly who benefits most and how to use this therapy most safely.
Precisely. Fine-tuning the approach for different patient subgroups is the next big challenge.
So it leaves us with a big question, really. Given these really compelling findings, how are treatment strategies for PAD likely to shift in the next few years? And maybe more importantly, what are the critical questions we still need to answer about balancing these powerful benefits against the real risks of bleeding, especially across the very diverse group of people living with PAD? Definitely food for thought. Thanks for joining us for this deep dive.